All right, welcome to your last module for CP physiology. In this module, this is going to be kind of your first introduction to hemodynamics monitoring. Actually, I shouldn't really say first introduction because back in um, respiratory assessment, we talked a lot about non-invasive ways that we can monitor hemodynamics in our patients. So, hemodynamics, sorry, click in for me. Hemodynamics is really the study. When we're talking about hemodynamics, we're talking about the study of the forces that influence the circulation of blood. Okay. So typically, when most respiratory therapists think about hemodynamic monitoring, they're thinking about putting in invasive lines to assess kind of the blood volume and the vascular resistance of the vessels. But I always like to remind people when we talk about hemodynamics that there's a lot of really great non-invasive ways that we monitor our patients' hemodynamic status. So some of those ways are, basically with your blood pressure, right? Our blood pressure tells us not only a little bit about the volume of blood or the cardiac output, but it also tells us about our systemic vascular resistance. So how much pressure the heart has to pump against to get that output or that stroke volume out of the heart. Um, Another assessment tool that we can have for hemodynamic status is just kind of those visual aids that we know about our patients. So, like color, if a patient that is having, we suspect is having a problem with the contractility of their heart or issues with heart failure, there's going to be some sort of a change in color, right? Blood and perfusion makes us nice and pink and rosy. And if we notice that our patients have kind of that pallor color or described as pallor, that means, they're kind of white and ghostly looking, then you would suspect that there's something wrong with their hemodynamics. Another thing could be like capillary refill. We use that to assess perfusion of the extremities. Um, Mentation, so level of consciousness, also helps us understand how well our patients are perfusing our brain. So a couple different ways that we hemodynamically non-invasively monitor our patient. But speaking about kind of the invasive monitoring tools that we have and some of the values we get from that is understanding that we can put in a couple different types of catheters to monitor invasively those hemodynamic status. So one of the main catheters is called a pulmonary artery catheter. It's kind of a balloon tip catheter that we put, either subclavian is a typical place for this, or they might put it in the jugular vein. It also could be placed in kind of the femoral veins, um, the basilic veins or brachial veins, which are in your arm, upper arm. Those are kind of the common insertion sites. And then the tip of this catheter is either going to be, if it's just a central line, it will sit in the right atria, which is just going to be able to measure the central venous pressure, which you're going to tell a lot about your patient's fluid status and blood volumes just by knowing their central venous pressure. If you want to do a little bit more in-depth monitoring, you can put this Swan-Ganz pulmonary arterial catheter in that then can be kind of floated further into the heart and eventually into the pulmonary arteries, where it can measure things like your pulmonary arterial pressures. And also in the pulmonary artery, you're going to be measuring your pulmonary capillary wedge pressure. And that sounds confusing. It's like, oh, if I'm measuring my pulmonary capillary wedge pressure, the tip of that must be in my pulmonary capillary bed, but it isn't. It is actually just sitting kind of further into those pulmonary arteries and measuring when that balloon is inflated, measuring pressures in the capillary beds, and giving us an assessment kind of the function of the left side of the heart. Okay. The other great function of these catheters is that we can also aspirate blood from it, and we can do assessments on mixed venous blood sampling. We can give fluids. We can determine your cardiac output. So these catheters are really fabulous at giving us a lot of information. Some kind of the primary reasons that we would insert a pulmonary arterial catheter is to assess how effective the drugs we're giving our patient are. We also do it for like diagnostic purposes or to monitor different types of therapies that the patient might be on. We also do it to collect data on like critical clinical assessments. So kind of it helps the values that we get from the pulmonary arterial catheter are going to help us determine whether the pulmonary edema that the patient experiences is cardiogenic versus non-cardiogenic. We're going to talk about that a lot more when we get to disease and fall. But these catheters kind of give us a lot of important information, do a lot of great things for us. But because it's invasive, there are some complications associated with it. So to insert the pulmonary artery catheter, like I said, you're going to usually insert it through the brachial, femoral, subclavian, or that internal or external jugular vein. So these are the main veins that are coming back to the heart. Okay, so it's going to have that continuous monitoring of catheter pressures, and you're going to get kind of a waveform along of these, like a pressure waveform along with the electrical activity of the heart, that EKG or ECG. So this is just kind of a fun YouTube video that talks about insertion. Move this over. Turn up the volume. Let's see why my volume's not working. Sorry, 1 second. So it's just demonstrating this going through the right atrium, into the right ventricle, and all the way up into the pulmonary arteries, where it is measuring that pulmonary arterial pressure. And then when we insert the balloon, we are going to be able to measure that wedge pressure. Okay. So we don't want, if you think about it, that wedge pressure, I'm inserting that balloon in there, I'm inflating that balloon, and I'm putting pressure on the capillary beds around that artery. So if I do that, that's going to cause some complications for that surrounding tissue. So let's going to go back to our slide deck here. Put this back over. Okay. So as you watch from that video, like the path that catheter travels, that can cause damage to any of the valves that are in the heart. We have valves between each of the chambers in our heart. If we have a catheter kind of wedged in between that valve isn't going to be able to open and close like it's supposed to. So that can cause damage to that tricuspid valve, that pulmonary valve. As I inflate that balloon, I can have something called a pulmonary infarction, meaning that infarction means a lack of blood flow. So as I inflate that balloon in the pulmonary artery to get that wedge pressure that reflects the function of the left side of the heart, I am going to be essentially stopping the blood flow to that tissue of the lungs, and then I can cause like some tissue damage and some infarction to that area. So I don't want to have that balloon inflated for longer than 10 seconds because I don't want to have any damage from lack of blood flow. The insertion of this sometimes can cause a pneumothorax, especially if they're doing the subclavian, which is a popular vessel to gain access to the heart through. As I insert the needle in that subclavian vein, that's where kind of the apex of the lungs are located at that same spot, and you can accidentally give your patient a pneumothorax. Because this catheter is sitting inside the heart and inside the heart chambers, that can make the heart upset, and you can have some arrhythmias, cardiac arrhythmias, dysrhythmias from that. It is a catheter that's hooked up to fluid, or should be hooked up to fluids, but since it's open to the environment as well, you can accidentally give your patient an air embolism. And then because this catheter is sitting in the pulmonary artery, and the pulmonary artery is getting this pressure from the balloon occasionally, you can accidentally rupture your pulmonary artery as well. which obviously would have some pretty severe consequences because that's where all the blood in your body is going to pass at some point through the pulmonary arteries, and the patient can bleed out really quickly. So there are complications, obviously, with the insertion and, having this in place. Also, there's any type of complications associated with invasive monitoring. So, anytime we have a line in our patients, especially a line that's going directly to our heart, we're going to increase our risk of infection. Insertion of lines increase your risk for bleeding. And then, as I mentioned before, because of where this line is located, that risk of dysrhythmia is also a consequence of doing invasive monitoring. So this, I really try to stress this in this conversation, is that, and reminding you of all those wonderful non-invasive hemodynamic monitoring tools that we have, is that this isn't going to be for every patient. As much as the information is valuable, we don't want to put a pulmonary arterial catheter in every single patient we see because of all these risk factors that are involved with it. Okay. So like I said, this catheter, if it is decided that we're going to place it, this catheter is going to monitor a couple different things for us. So the first being our central venous pressure. Okay, so your pulmonary arterial catheter will measure this. You can also have something that's simply called a central line, which will only monitor the pressures in your right atria, or your central venous pressures. Okay, this is going to give you a lot of very good information as we talk in the next slide about hemodynamic, the volume status of your patient, because it's where all of the blood that's returning to your heart goes. So it tells me a lot about whether I have enough volume in general. Then as we move on, we're going to be able to assess our right ventricle pressures. So your RV pressures. This isn't as kind of impactful or important as those CVP pressures, but you are going to see this change in waveform as it passes through the right ventricle and as it moves into the pulmonary artery. Okay, so you see kind of a change in this waveform as it moves into the pulmonary artery. In the pulmonary artery, then we're going to be able to determine things about the patient's kind of how our lungs and the pulmonary vascular resistance in our lungs are affecting our heart. And as we move up and further into the pulmonary artery, we're going to be able to assess this pulmonary capillary wedge pressure, where you see this kind of dampening of this pressure waveform again. And this is going to tell me a lot about function of my left side of my heart. So even though it's inside the pulmonary artery, so that's where it's located when we're taking this measurement, this measurement is assessing the capillaries around that vessel and the tissue around that vessel. So it's going to give you a little bit better picture of how our left ventricle is working and things like cardiac output, stroke volume. So I think I'm going to take a pause right here, and I'm going to do this in another kind of little mini lecture at the synchronous session and post that as well. But when I think of hemodynamics, I always feel like it's easiest to imagine this when you have the heart split in two. Okay, so I draw this a lot when I talk about hemodynamics. So I'm drawing my right side of my heart, and then over here is the left side of the heart. Okay, and in between is my lungs. Right, so this is the right, this is the left. So if we imagine that what's going to affect the right side of the heart, this is my superior and inferior vena cava. So this is my vena cava here. Okay, so this is where the blood returns to the right side of the heart. Okay, my CVP then gets monitored over here in the right side of the heart and reflects right-sided heart function. And it also reflects the blood that's returning to the heart. So, my hypovolemia is going to be over on this side. It's going to be monitored here. So hypervolemia. here in my lungs, this is where I'm going to be kind of looking, or when we're assessing our lungs, we're looking at our pulmonary vascular resistance and our pulmonary arterial pressure, our mean pulmonary arterial pressure. So the pressures that are in these vessels in the lungs, and that reflects our lung health. So things that are going to primarily affect our pulmonary arterial pressure or our pulmonary vascular resistance are things that are affecting the lungs, like pulmonary hypertension, COPD, mechanical ventilation. All of those things are going to pulmonary embolisms. Those are primarily going to be affecting the lungs. Okay. So my primary issue is going to be here. And then because my right heart has to empty into my lungs, it's going to create a back pressure and have some secondary effects to the right side of the heart. Okay, so my left side of the heart then, or my pulmonary capillary wedge pressure, is reflecting kind of the left side of the heart, and like my cardiac output is kind of a reflection of everything downstream. So everything downstream is ultimately affecting my cardiac output and stroke volume. Okay, so just a refresher too, and I posted a really good video. I really recommend you guys watching the additional videos I posted on the module page about reminding you about afterload, preload, and contractility. So when we talked about these originally, we talked about them in when we were talking about chapter 5 in CP Phys. So preload is meaning kind of how much pressure is in this vessel before that heart squeezes. Okay, so preload is going to be affected by the volume of blood that returns to the heart. So if I have hypovolemia, that is going to mean that my preload for this right ventricle is really, really low. So the pressures in that right ventricle will be low because my preload is low. I hope that makes sense. So think about it as like you're filling up a pitcher, and you're filling up this pitcher with water. So the amount of water you can pour out of that pitcher is dependent on how much water you put into it in the first place. So if I fill my pitcher up all the way at the top, then I'm going to be able to pour a full pitcher out of it. Okay. If I only fill it up halfway, if my preload's only half of what it's supposed to be, then I'm never going to be able to pour a full pitcher out. I will only ever be able to pour a half pitcher out. Okay. So afterload is what you have to pour that pitcher against. Okay. So if I have a full pitcher, but then my afterload is increased, so the size of the cup that I'm trying to pour that pitcher into is decreased, then I'm never going to be able to pour the full pitcher out. I can only pour, a quarter of the pitcher out because my afterload cup is a quarter of a pitcher. Okay, so kind of think of that imagery, or that imagery at least helps me a little bit. It's afterload is what we have to work, our heart has to work against in order to pump. So preload is what got put into our heart, that our heart can, the potential that our heart can pump out. And then the afterload is what my heart has to work against. So that really is your vascular resistance in a lot of ways. So if you imagine it this way. So I'm just going to erase some of this. And again, I'm going to go through this again at synchronous session, your first and second week, to make sure that, we're doing this with you guys, to hopefully make sure you guys understand it. So I'm going to erase this and this. Okay. So if I think about my afterload being of my right side of my heart, my afterload then would be my pulmonary vascular resistance. So how narrow these blood vessels are that blood has to pump through. Okay, so if I narrow up these blood vessels because I have a pulmonary embolism and I got a clot in there that's making those blood vessels more narrow, my full side, if I fill up my right side of my heart completely with blood, but I can't pump all of that blood out because my vascular resistance only can take half, then I'm going to have increased pressures here primarily, and then there's going to be a back pressure here because this heart can't empty completely. We're going to keep talking about this, so hopefully nobody's stressing too much right now. So I'm going to exit my drawing here. Okay. So going back to the central venous pressure, let's just take this in chunks. Our central venous pressure is that measurement, like I said, of that right atrial pressure. So it reflects not only like that systemic venous return, so how much blood came back to the heart, and that ventricle preload, so how much blood got back to the heart, how much blood's in that vessel. But it's also like secondarily affected by anything downstream from it. So downstream meaning anything that's happening in the lungs, anything that's happening in the left side of the heart. So this measurement can be monitored with both that pulmonary arterial catheter or just a CVP catheter, or sometimes called the central line. Okay, so when we're using a CVP, you're going to be evaluating for things that are going to cause it to increase, like cor pulmonale, pulmonary hypertension, cardiac tamponade, COPD, lung collapse. All of those things are going to increase your CVP, okay? Because it's either directly affecting the heart, the right side of the heart, or indirectly affecting the right side of the heart. So we typically are going to see signs and symptoms of that increased CVP demonstrated to our patient non-invasively. So my patient, if they have a high CVP, that means that there's a lot of pressure going on that right side of the heart. Right side of the heart can't pump effectively to the lungs. So the patient is going to experience some shortness of breath. They might appear dizzy because if the blood cannot leave the right side of the heart and go to the lungs and then go to the left side, come back and go to the left side of the heart, the patient is going to be dizzy from lack of perfusion to the brain. And they might start experiencing things called peripheral edema and that jugular vein distension. And that happens because as that CVP increases, that is going to have a negative impact on blood return to the heart. So if you think again of this as a pitcher, so I have a pitcher of water. Sorry. Oh boy. 1 second. It's taking my drawer tool a second to catch up with me here. Okay, so if I think about the right side of my heart as a pitcher or a glass of water, okay, this glass of water is supposed to be getting pumped out to the lungs, right? As I fill up this glass of water with my superior vena cava empties into this glass, and my inferior vena cava empties into this glass, okay? If this glass isn't emptying completely, if this glass just keeps getting fuller and fuller and fuller and fuller and can't empty into the lungs appropriately due to anything that's going to cause increased pulmonary vascular resistance, then all of a sudden, this hose is going to start getting backed up and blood's going to start backing up the superior vena cava, and blood then is going to start backing up in the inferior vena cava because it can't empty anymore into this bucket. Okay, so as blood backs up into the superior vena cava, that is going to cause jugular vein distension. And as you guys remember, hopefully from respiratory assessment in survey class, that is where your jugular veins, which are located in your neck, kind of bulge out. Okay, and that reflects that increase in that CVP. Okay, peripheral edema also can be an indication that you have an increase in CVP because the blood is not able to return to the heart, the right side of the heart, like it's supposed to. Okay, so I said the normal value for your central venous pressure should be somewhere between 0 and 8 milliliters of mercury, okay? I would know these normal values for the exam. I'm only going to ask you 2 of them. I'm not going to tell you which 2 I'm asking you, but I would know these values for the exam, what the normal range is, okay? That's kind of the big goal right now for you guys with your first foray into hemodynamics, is making sure you kind of understand normal values a little bit. So there's at least 2 questions on the exam that ask you this directly. So I would know my normal values. There are also some computed hemodynamic values that are things that we calculate based off of these values that we directly measure. You do not need to know these normal ranges. You do not need to know the calculations for how you achieve them, okay? So again, know these normal ranges, the ones that you're going to directly measure. You do not need to know the calculated normal ranges, and you do not need to know how to calculate them. All right. I do want you to kind of understand some of these values. So we'll talk about them more in depth, like your stroke volume indexed, cardiac output, cardiac indexed, and then your right ventricle work and your left ventricle work. All of these things are going to be affected the same way. So the things that increase these will increase them all. The things that decrease these will decrease them all. So things that are going to increase, things like my stroke volume and my cardiac output, which are probably the big ones that I want you to understand, is that we have some types of medications that will affect these. So we have medications that are called positive inotropic drugs. What these drugs do is it increases my contractility of the heart. So it's going to make my heart squeeze harder. Okay, so that's your dopamine, your epinephrine, dobutamine, isoproterenol. You don't have to know the names of these medications. For the exam, I just want to introduce them because when we get to cardiogenic pulmonary edema or congestive heart failure next semester in disease, I don't want this to be that to be the first time I say these words to you. We have negative inotropic drugs, which decrease our contractility. So it makes the heart squeeze a little bit less, which are propranolol, metoprolol, atenolol. These are medications that sometimes congestive heart failure patients are taking at home to try to manage their fluid balance and and their hemodynamic status. Okay, again, you don't have to know these for right now. I just wanted to introduce them. There are some things that are outside of medications that are going to increase my stroke volume and my cardiac output. Okay, so hyperthermia, hypervolemia, septic shock, the early stages of it, and that decreased cardiovascular resistance. If you think about them, like hypervolemia, for example, I'll take the easy one, hypervolemia. That means I have a lot of volume. So if I have a lot of volume going into my heart, then I'm going to have a lot of volume going out of my heart. All else created equal. So hypovolemia will increase my stroke volume and my cardiac output. We manage our patient's cardiac output by giving them fluids to try to increase their cardiac output or decrease it, depending on what's wrong with our patient. Septic shock. In the early stages of septic shock, which is the shock that patients experience when they have like a systemic infection, they are going to have that increased cardiac output because the heart and lungs are going to be trying to work really hard to increase our perfusion to our body to try to help fend off this infection. So in the early stages, our body's going to work really hard to increase perfusion to the tissues. Hyperthermia, again, in order to maintain hyperthermia, we need good perfusion. So that's going to increase our cardiac output and stroke volume. And then decrease vascular resistance. So the vascular resistance, again, is kind of reflective of our afterload, what my heart has to work against to pump. So if I don't have a lot of resistance, then every squeeze of my heart is going to be very effective at getting blood out of it. if I don't have any resistance against that squeeze. So if I decrease my my vascular resistance, which we do that through like vasodilators, right? So a common vasodilator would be nitroprusside. We give that to patients. If you look at the clinical connection at the end of your chapter, or your case study number 1, at the end of your chapter, they talk about giving nitroprusside to a patient to decrease the effects of that elevated afterload, that systemic vascular resistance. So we give drugs like nitroprusside to correct that elevated afterload and decrease our vascular resistance. That will be important for the test. I didn't say you needed to know any of the other medications, but I would know that one. Then things that are going to decrease my stroke volume and my cardiac output are going to be things that, like late stage septic shock, our body's kind of shutting down. It's not working as effectively as it once was. So we're going to have a decrease in that cardiac output and stroke volume. Congestive heart failure is when I have my left ventricle of my heart doesn't pump effectively. So which is what creates the cardiac output, if you remember from chapter 5. So that congestive heart failure will result in blood not getting pumped out of the heart to the body, the rest of the body. So my stroke volume or cardiac output would decrease. That blood has to go somewhere though, so it starts backing up. And unfortunately, the thing that's behind the left side of the heart, if you remember from my drawing, is the lungs. So that all that extra blood and fluid backs up into our lungs and causes cardiogenic pulmonary edema. PEs block the blood in the middle, right? It comes back to the right side of the heart, gets pumped to the lungs, but then gets blocked in the lungs. So it can't come back to the left side of the heart and get pumped to the rest of the body. Myocardial infarctions, just depending on where it is going to affect the contractility of the heart, which will decrease my stroke volume and cardiac output. And things like mechanical ventilation. So if I hyperinflate the lungs by giving PEEP or mechanical ventilation, that is going to increase that pulmonary vascular resistance and then kind of again block that flow of blood from the right side of the heart to the left side of the heart, and then affect how much then gets pumped out to the rest of the body. Okay, so there's a couple clinical connections. This chapter, as you look at it in your book, you might be like, oh, this will be easy. There's not that much to it. But this, I feel like this is like a very much application-based chapter. You better understand how this works. And there's a lot of clinical connections in here that I really want you to focus on. So the first one being cor pulmonale. So cor pulmonale is a disorder that is really the enlargement of the right ventricle. Okay, it's caused by lung disease, essentially. So the blood gets back to the right side of the heart, but then when the right side of the heart tries to pump it to the lungs, there's an increase in pulmonary vascular resistance in the lungs that cause it to not get pumped out. So that right ventricle can't pump effectively to the lungs. It's also sometimes called right-sided heart failure. And it's going to primarily affect then, because it's those right-sided heart pressures, it's going to affect your CVP and your RAP. So those are the things that are primarily affected. Okay. And if you think about your, oh my goodness, this drawer thing is so slow in this application. If you think about your drawing again, the right side of the heart, and then the left side of the heart, and the lungs being in the middle. If the right side of the heart isn't able to pump blood this way, okay, because it's blocked some way, or it doesn't have good contractility or whatever, either the afterload is increased or the contractility of the right side of the heart is decreased, then I'm going to see increased pressures here because the blood isn't going to be able to go where it's supposed to go. It's coming back to the heart through the superior inferior vena cava. The heart's accepting that blood, but it cannot effectively pump it out of the right side of the heart to the lungs. So I'm going to see primarily an increase in my CVP and RAP. Okay. Then everything after this, the right side of the heart, could potentially become decreased, right? If my blood can't leave this side of the heart and go downstream, if you think about these as lakes, sometimes I use that imagery. Like I have a lake and I have a river connecting to the other lake. My top lake here, if this water can't go down the river to this lake down here, then all that lake water is going to swell and swell and swell and swell and swell up here. Okay, due to some sort of blockage downstream. So anything then downstream is going to be decreased. So my PAP would be decreased because it's downstream. And my PCWP would be decreased because it's downstream. Another clinical connection that we talk about is congestive heart failure. So this is CHF, congestive heart failure, left-sided heart failure, or sometimes people talk about it as cardiogenic pulmonary edema. This happens when the left ventricle is unable to pump the blood effectively. And that can again be because the contractility of the left ventricle is decreased, or because of the systemic vascular resistance is increased. You know, something that's going to cause that blood to not want to go. So in congestive heart failure, the primary thing that's going to be affected then is what we measure in that left ventricle, which is the PCWP, okay, the pulmonary capillary wedge pressure. Okay, the pulmonary capillary wedge pressure increases. Okay, let me do my drawer again. Oops. Oh my goodness. Sorry. This is why I like to do this at synchronous session, because screencast doesn't do the drawing very easily. Okay, so my right heart, my left heart, and my lungs again. So if my problem is that this left ventricle isn't able to pump blood out of it, okay, effectively, then this pressure here is going to increase primarily, which is my PCWP, which is what measures or reflects my left ventricle, okay, because this blood is going this way and filling this chamber up here, but if that blood cannot exit the heart and go to the body, it's going to all start getting built up in that chamber, and then it's going to start doing a back pressure and causing a back pressure, which then will cause a secondary increase of anything behind it. So my pulmonary arterial pressure, my right atrial pressure, right atrial pressure. But because the blood isn't actually coming out of this left ventricle very well, typically you will see a decrease in systemic vascular resistance because you don't have any blood, because you don't have any cardiac output. Your cardiac output's going to be decreased. Oh my God, this stupid cardiac output's decreased. Rar doesn't want to like me. Okay, so my cardiac output decreases, my systemic vascular resistance decreases because of the lack of cardiac output. So then usually my CVP doesn't change at all, because even though this right atrial pressure is increased, I'm not getting a lot of blood back to that through that systemic venous return. So my CVP sometimes doesn't get affected. Okay. And again, you don't have to master this at this point. Big takeaways I want you to do is just understand what these diseases mean hemodynamically. So congestive heart failure is that inability of that left ventricle to pump effectively. And I want you to know what the primary value it affects. So like I said with cor pulmonale, that's right-sided heart failure. It affects your CVP, RAP primarily. Congestive heart failure is left-sided heart failure or the inability of that left ventricle to pump, and it primarily affects your PCWP. I will torture you a lot more next year, spring and fall semester, putting the rest of these pieces together. But right now, this is just your introduction. I have to be patient while this thing thinks. Okay, COPD. Okay. COPD is, those respiratory disorders. They're classified. There's 4 different respiratory disorders that make up COPD. It's your chronic bronchitis, emphysema, cystic fibrosis, bronchiectasis. All of those are your chronic pulmonary disorder, obstructive pulmonary disorders. Okay. So because it's primarily affecting the lungs, the value that's going to be increased or primarily increased will be your pulmonary arterial pressure. Okay. I just want you guys to have an awareness that, like, your book gives you your pulmonary arterial pressure being like a range of 9 to 18 millimeters of mercury. Sometimes some references are going to actually give you it as like a blood pressure. So just give you an example of that. So sometimes they give it to you as an actual blood pressure, which would be like saying, oh my goodness gracious, I cannot stand this. Listening to me complain. Waiting oh so patiently for my drawing tool to pop up. Okay, there we go. So sometimes they might give you your pulmonary arterial pressure instead of giving you the mean. I hate this thing so much. Actually, let me see if I can. Oh, God, I hate this. Instead of giving you like something within the range of 9 to 18, they might give you 25 over 5, just like you would see a regular blood pressure, right? And then it's just kind of important, this might come up in the future for you, just to know how to calculate your mean when you're given an actual blood pressure. So just like with systemic blood pressures, you would get like, a normal systemic blood pressure is 120 over 80. So normal pulmonary blood pressures are 25 over 5. Okay, so it's important that your pulmonary pressures are always lower than your systemic pressures, because blood is everything in life is going to go path of least resistance. It's going to go from areas of high pressure to areas of low pressure. It's not going to go from low to high. So to calculate out my mean arterial pressure, given a pulmonary pressure of 25 over 5, I would just take, let me see if the text thing works better. So 25 over 5 is the value I was given. To calculate out my mean, I would just take this is the calculation down below. I take my systemic pressure, which is 25. I'm going to add it to 2 times my diastolic pressure. So 2 times 5 is 10. And then I'm going to divide the whole thing by 3. Okay. Actually, just put some brackets in here so it's clear, super, super clear. So 25 plus 2 times 5 is 25 plus 10, which is 35, divided by 3. Just type this all out to make sure those of you that despise math are following. By 3. So 35 divided by 3, which gives you about 12, right? 35 divided by 3 gives you about 11.66. 11.667 is what my mean, or my mean PAP would be. Okay, so that fits within that normal range. So just to make sure that you understand that, you will not have to do this math on the test, but I just wanted to make sure you know where these values kind of come from with mean arterial pressures. And this is the same calculation whether you're doing pulmonary pressure, mean pulmonary pressure, or mean systemic pressure. So and that, okay. Okay, so we've talked a lot about conditions that are going to increase your values, or at least some of your values. Now we'll talk about like hypovolemia, which is what's going to cause a decrease in your values, or hypervolemia, which would cause an increase in all your values. So when you talk about volemia, or how much blood is available, if I don't have enough blood coming into the system, that's going to have a primary effect on my CVP. Okay, if I have too much blood coming back to the heart, that's going to have a primary effect again on my CVP, but instead, hypovolemia decreases my CVP. Hypervolemia will increase it. So some common causes of hypovolemia are going to be your like dehydration or bleeding. So if I gave you an example of somebody who had a bunch of gunshot wounds, you could infer that he would have a lot of bleeding, and that would cause him to be hypovolemic, and his CVP would be decreased. Vomiting also, just because of the loss of fluid. Severe burns, there's a lot of loss of fluid with severe burns, and different types of drugs can cause hypovolemia as well. So primary drug classification would be your diuretics. Furosemide is an example of a diuretic that's commonly used. The generic name or brand name is Lasix. And diuretics work to decrease your preload. So it decreases the amount of volume that's coming back to that right atria, because you're peeing out more of your volume. Vasodilators, as I mentioned before, remember I said there's one drug you need to know for the test. Vasodilator, nitroprusside, talked about in your case, the case study at the end of the chapter, decreases your afterload because it vasodilates. It decreases the pressure that's on those vessels, so it makes it easier for the blood to get pumped away from the heart out into the rest of the body. So that will also decrease all of your pressures across the board. One thing, if you think about your cardiac output in general, like we have 4 to 6 milliliters per minute is your cardiac output for most adults. That blood, if all my vessels are vasodilated to the extreme, which is what happens in septic shock sometimes, late stage septic shock, then all my blood is filling up all this vasculature in my periphery, and then it doesn't return to the heart. So even though I didn't lose volume in the sense where it's still in my vasculature, I still lost that volume in the sense that it's all spread out throughout my body, and it's not returning. There's not enough pressure underneath it to return it to the heart and have it participate in this gas exchange. Okay. So stroke volume is the amount of blood that's ejected from the ventricles with each contraction. Okay, so it's going to be affected by those preload, afterload contractility things. Stroke volume index is that stroke volume divided by the surface area. So again, depending on the size of person you are, you might have what might be a normal stroke volume for me, who's short, is not going to be enough for Shaquille O'Neal, right? So that index is going to increase or decrease, the same as any of my cardiac outputs, and stroke volumes increase or decrease it, and it's going to be affected by the overall blood volume status and the amount of venous return coming back to the heart and how well the heart is pumping. Your cardiac index is that cardiac output divided by the body surface area as well. So again, we can't think about cardiac output in just number value. Like if I have 4 milliliters of cardiac output, that seems pretty reasonable for somebody of my size, but that same 4 milliliters to Shaquille O'Neal would not be enough. And that's where cardiac index kind of is a better reflection of whether that output is adequate for that person's body size. Again, you do not need to calculate any of this stuff for the exam. I'm just going through definitions and putting the formulas there, so if that helps mathematically minded people. Your right ventricle stroke index is the amount of work required by the right ventricle to pump blood. This then is a reflection of that, not only the contractility of the right ventricle, so how hard that right ventricle can squeeze, but anything that increases the afterload. So anything that increases the afterload of the right ventricle is anything that increases the vascular resistance in what follows the right ventricle, which is the pulmonary system. Okay, so your afterload on that right ventricle is your pulmonary vascular resistance. That's what that right ventricle has to pump against. Okay, this work also is going to reflect not only what it has to pump against, that pulmonary vascular resistance, but the contractility of that right ventricle, how well those muscles work to squeeze. Your left ventricle is kind of the same thing, but it works. It's the work required of the left ventricle instead of the right ventricle stroke work index. So it's how the amount of work required by that left ventricle, again, reflects the contractility of the left ventricle and the afterload, any increases in the afterload on the left ventricle. So the afterload of the left ventricle isn't the lungs and the pulmonary vascular resistance, but the systemic vascular resistance, because as the blood leaves the left ventricle, it goes to the rest of the body, not to the lungs. So again, that pulmonary vascular resistance, that measurement reflects the afterload of that right ventricle. So it's what that right ventricle has to pump against, and this is how you calculate it out. So it's not something that's directly measured. It's calculated based on these other measurements. You do not need to know how to do the math. Factors that are going to increase my pulmonary vascular resistance can be any type of chemical stimulant. So as we learned in controls of breathing, we know that we have chemoreceptors in our body that are impacted by CO2 levels, PaO2 levels. So those can act as chemical stimulants to increase your pulmonary vascular resistance. We can have pharmacological agents that increase your pulmonary vascular resistance. So epinephrine is a vasoconstrictor. So is norepinephrine, butamine, dopamine. All of those are vasoconstrictors that are going to increase that vascular resistance. You can have some pathological factors like pulmonary emboli, cirrhosis that affects the vascular walls and restricts the vascular walls. You can have emphysema or pulmonary fibrosis that affects, causes destruction to the capillary beds. Or you can have vascular compression from a pneumothorax. That can all increase your pulmonary vascular resistance. Okay, so I know you're going to ask this. I do think it's important that you know these charts that I'm covering in here. I highlighted specific things in these charts that I think you're going to want to know for the exam, okay? I don't think it's fair of me to ask you to memorize every single subcategory in this, but know kind of the big ones. Some other increases in pulmonary vascular resistance would be like your hyperinflation of the lungs. So mechanical ventilation is going to cause hyperinflation. That's same thought process of that vascular compression as, something in the thoracic cavity takes up more space, it's going to compress other things. Okay, and then things that are going to decrease your pulmonary vascular resistance, the more oxygen that you have available will decrease it. Isoproterenol, calcium channel blockers, those types of things will cause some vascular dilation. And then your hormonal substance, acetylcholine, causes that being released causes vascular dilation. Prostaglandins also do. Okay, so that's kind of talking about pulmonary vascular resistance. Now, systemic vascular resistance, I mentioned, is that afterload, not for the right ventricle, but for the left ventricle. That is how you calculate it. You do not need to know how to calculate it for the exam. There's several factors that are going to increase or decrease the systemic vascular resistance. So primarily those late stage septic shock is going to cause changes to the systemic vascular resistance and increase your systemic vascular resistance potentially. And then you have your vasodilating agents, is that going to decrease it. So again, that nitroprusside being one that decreases the afterload on the left side of the heart, which is reflective of your systemic vascular resistance. Okay. Alrighty. So hopefully nobody's panicking yet. I know that hemodynamics is kind of miserable when you first start learning it. So, take time to watch this lecture, maybe watch it a couple times. During synchronous session, we're going to be going through kind of that drawing of like how things are broken down and some of the imagery to try to help make this make a little bit more sense. This really does, once it clicks for you, it's pretty intuitive, like, okay, well, this is downstream of this. So it becomes a little bit more that you're not just memorizing, but that it actually makes sense. All right, so as always, let me know if you have any questions.